Evening to all the viewers present here with us today. This is Batul from IGCP, and I would like to welcome all the viewers who have joined our platform for the better exchange of knowledge that is going to be shared by our keynote speaker, Doctor, for today's session. Well, he needs no introduction at our platform, but it's my pleasure and honor to introduce such a renowned pediatrics Professor Dr. Bharatji Parmar, sir. Sir is MD, DHA, FAIMS, Professor and Head of Pediatric Department at Zydus Medical College and Hospital, Gujarat, and National Trainer for Recent Protocol Management of Dengue. With Sir's wonderful insights, we'll be learning about today's topic, which is dengue fever, and a very important topic. Right now, we should all be aware of what this dengue fever is about and how to take precautions. So, now moving on to today's session, before going on, we will have a brief outlook on what the topic says. Dengue fever, a mosquito borne viral illness, is a significant global health concern, particularly in tropical and subtropical regions. Recent research has provided newer insights into various aspects of dengue fever, including its epidemiology, clinical manifestations, pathogenesis, diagnosis, and management. We'll be learning more about prevention strategies, early detection, and timely treatment to reduce the burden of this potentially severe and life threatening disease. So, now without any further delay, I would like to welcome Sir at our forum and would like to hand over the session to him for his precious talk to begin. Sir, over to you.
Okay. Good evening to all. First of all, I am very thankful to IJCP Group giving opportunity to me for highlight my views regarding dengue fever. What is a newer insight? Dengue is a self-limiting viral febrile illness transmitted by Aedes aegypti mosquito to the human. It is characterized by biphasic fever, myalgia, arthralgia, rash, leukopenia, and thrombocytopenia. The dengue hemorrhagic fever is characterized by abnormalities in hemostasis and the leakage of fluid and the protein from capillaries, which result in hemodynamic compromise and shock. It is called dengue shock syndrome. Current molecular and gene study shows that NS1 antigen and antibody dependent enhancement act in a concert with the complement system and chemokines, leading to increased vascular permeability. Newer insight in entomology give information about the transmission of dengue from vector to the host, thereby helping in preventing the disease. However, even with the newer insight in the prevention, diagnosis and treatment remain largely supportive and morbidity in pediatric population remain high. Manifestation of dengue due to vascular permeability syndrome with immune complex mediated immunopathology. In 2009, the WHO defined the spectrum of disease as the actual number of the dengue cases are underreported and many cases are misclassified. One recent estimate indicate 390 million dengue infection per year. What is the morphology of dengue virus? Dengue virus is an envelope positive sense single standard RNA virus that produce a spherical particle with a diameter of approximately 500 angstrom, and four clearly defined types of dengue exist, namely DEN 1, DEN 2, DEN 3, and DEN 4, as determined by plaque reduction neutralization test using antibody raised by infection of monkeys and fluorescent antibody test using monoclonal antibody raised in mice. Vector and transmission. Aedes aegypti, a daytime biting mosquito, is a principal vector, and all four virus types recovered from the naturally infected Aedes aegypti. The most of the tropical area, Aedes aegypti highly domesticated and breed in water stored for a drinking, washing, bathing, and any container collecting fresh water. Transmission of dengue by Aedes aegypti may be explosive and involve as much as 70 to 80% of the population because Aedes aegypti has a limited flight range, spread of the virus mainly by the movement of infected humans. Dengue virus replicate in gut, brain, and salivary gland of infected mosquito without apparent harm to the adult mosquito. Because female mosquito take repeated blood meals, long-lived female mosquito have a greater potential as a vector. Factor associated with dengue transmission. It is due to improper water drainage, haphazard construction, rainwater accumulation in discarded tires, flooding, poor water drainage system, and tropical climates. So these factors responsible for dengue transmission. Aedes aegypti mosquito bite in daytime and transmission of the dengue is maximum at a workplace and the female have more severe disease. Case fatality rate is highest among the children and predominant age to be affected between 16 years to 60 years and malnourished children are relatively protected against severe dengue. First infection with dengue virus, it leads to dengue fever and subsequent infection with second dengue virus leads to dengue hemorrhagic fever. Infection with DEN 2 is a severest and DEN 1 and DEN 4 it lead to mild disease and infection with dengue 3 DEN 3 leads to hepatitis and hepatic encephalopathy. Mild dengue presents with fever, headache, rash, retroorbital pain, myalgia, arthralgia, and bone pain. And severe dengue presents with hemorrhage and capillary leak, leading to pleural effusion, ascites, shock, and bleeding. So, natural course of the severe dengue infection, that is the first 5 days incubation period and fever for 12 days, up to 12 days, capillary leak from 5 to 15 days, thrombocytopenia 5 to 15 days. So, monitor for this hypovolemia up to 17 days and resorptive phase, monitor for fluid overload on fluid therapy. So the days of illness, the temperature, there's a 40-degree centigrade, right? And there is a viremia, and then there is hematocrit is rise from 4 days, and there is a organ impairment also occur after 6 days. So these are the uh, stages of this dengue illness. There is a febrile illness, critical illness, and the recovery phase from first day to 15 days. Clinical manifestations of the dengue in children, clinical manifestation of both primary and secondary dengue infection are varied. They often have leukopenia, pharyngeal ingestion, maculopapular rash, petechiae, facial flush, liver enlargement, cold extremities, with primary and secondary dengue infection. Published data suggests that primary infection with the dengue virus type 2 and type 4 are largely inapparent. By contrast, primary infection with dengue virus 1 and 3 in children more often result in a mild to moderate febrile disease, sometimes accompanied by low grade vascular permeability. Epistaxis, fatigue, purpuric lesion are uncommon in children. In classical dengue fever, seen most frequently in adult, after an incubation period of 2 to 7 days, patient experience sudden onset of the fever, which rapidly rise from 39.5 degrees centigrade to 41 to 0.14 centigrade, that is 103 Fahrenheit to 106 Fahrenheit high grade temperature, and usually accompanied by frontal or retroorbital headache, transient macular generalized rash that blanches under pressure may be seen during the first 24 to 48 hours of the fever, and pulse rate may be slow in proportion to the degree of fever. Myalgia and bone pain occur soon after onset and increase in severity. During the second to the sixth day of fever, nausea, vomiting are likely to occur. 1 or 2 days after the defervescence, generalized morbilliform rash, maculopapular rash appear with sparing of palm and sole, and it disappear in 1 to 5 days. In some case, edema of palm and sole may be noted. About time of appearance of this morbilliform rash, the body temperature which has fallen to normal and may become elevated slightly and establish the biphasic temperature curve. Dengue vascular permeability syndrome. The dengue vascular permeability syndrome, there is DVPS, is a core pathophysiological phenomena in dengue hemorrhagic fever and dengue shock syndrome and severe dengue. In infant and children, progression of illness is characteristics. A relatively mild first phase, that's the febrile phase, with abrupt onset of fever, malaise, vomiting, headache, anorexia, and cough may be followed after 2 to 5 days by acute epigastric abdominal pain and lassitude. In the second phase, that's a critical phase, the patient usually has cold and clammy extremities, warm trunk, flushed face, diaphoresis, and anuria. Patients are lethargic and restless and irritable and complain of epigastric pain. Frequently scattered petechiae appear on a forehead and extremities, and spontaneous ecchymosis may develop at easy bruisability, and the bleeding at the site of venipuncture are common finding. Circumoral and peripheral cyanosis may occur, and there is slow venous filling time. Respiration are rapid and often labored, and pulse is weak, rapid, and thready, and heart sounds are faint. Systolic pressure may remain normal, even elevated, because of compensatory sympathetic activity, and patient appear deceptively well, retaining full consciousness. When hypotension ensues, the pulse pressure become narrow less than 20 millimeter of mercury. Later, systolic and diastolic pressure fall rapidly. The liver may be enlarged, become palpable. X-ray chest shows unilateral, mostly right or bilateral pleural effusion, and USG evidence of plasma leakage may lead may be detected in some cases within 3 days after the fever onset. Other findings such as thickening of gallbladder and up to 10% patient may have a gross ecchymosis and GIT bleed, and during the transition from febrile to the critical phase, it is a crucial for clinician to be aware of warning sign of impending vascular permeability, which are persistent vomiting, increasingly severe abdominal pain, rising hematocrit, and falling platelet count in a critical phase. After 24 to 36 hours of period of crisis, there is a convalescence is fairly rapid in children to recover. There is a recovery phase. The temperature may return to normal before or during the stage of shock. It should be noted that DVPS occur regularly in infant in the country where the multiple dengue virus are hyperendemic, and these baby are born to the mother with two or more lifetime dengue infection but do not occur when mother have experienced only single dengue infection before pregnancy. Infant predominantly aged 5 to 10 month experience physiologically the same dengue vascular permeability syndrome as the older children, except that they are more difficult to diagnose and treat, and the case fatality rate are higher. Definition of dengue. The classification of dengue, there is a probable dengue. When you call probable, so there is the patient live in or travel to the dengue endemic area, has a fever or a two of the following. There is a nausea, vomiting, rash, aches and pain, positive tourniquet test, leukopenia, or any warning sign. So this is probable dengue. Dengue with the warning signs. These are abdominal pain and tenderness, persistent vomiting, clinical fluid accumulation, mucosal bleeding, lethargy, restlessness, and liver is enlarged tender more than 2 centimeters, and laboratory there is increase hematocrit with rapid decrease in platelet count. So these are warning signs for dengue. What is a severe dengue? When child presented with dengue, there is a severe plasma leakage, dengue shock syndrome, fluid accumulation with respiratory distress, there is a pleural effusion, severe bleeding as evaluated by clinician, there is a petechiae, ecchymosis and epistaxis, and severe organ involvement. The liver, there is SGPT more than 1000 units, and CNS, there is an impaired consciousness, and also involvement of heart and other organ in severe dengue. What is the immunopathogenesis of dengue? Epidemiological, clinical, and virological study of dengue hemorrhagic fever. So, dengue hemorrhagic fever, dengue shock syndrome in human have shown significant association between dengue vascular permeability syndrome and dengue virus infection in presence of circulating dengue antibody, whereas it is passively acquired from the mother or actively acquired from the previous dengue infection. Risk of developing vascular permeability syndrome is inversely correlated with the age. The youngest children are a highest intrinsic risk for DVPS. In human circulating antibody appears to have a two biological activity, namely neutralization of virus and enhancement of infection. Studies have shown that non-structural protein, there is NS1 antigen, activate the toll-like receptor, there is a TLR4 on a primary human myeloid cell, resulting in increased production of chemokine and pro-inflammatory cytokine. As a byproduct of this interaction, there is toll-like receptor 4, there is increased vascular permeability syndrome. In earlier study, NS1 was shown to activate complement system by alternative pathway and to target liver cell, promoting intracellular dengue virus infection, and it was detected as a complex with thrombin in acute phase blood of dengue patient. Available study and literature suggests that direct role and toxicity of DAN4. NS1 antigen, it provides single causal mechanism for dengue vascular permeability syndrome. Laboratory diagnosis in case of dengue fever. During the febrile phase, the detection of viral nucleic acid in serum by means of reverse transcriptase polymerase chain reaction, there is RT-PCR assay, and detection of virus express soluble non-structural protein, there is NS1 antigen by ELISA technique. There is an enzyme link immunosorbent assay, or the lateral flow rapid test is sufficient for confirmatory diagnosis. So diagnosis of this dengue by RT-PCR and ELISA. For primary infection in a person who have not been infected previously, the diagnostic sensitivity of NS1 detection in a febrile illness can exceed 90%, and antigenemia may persist for several days after resolution of the fever. The sensitivity of NS1 antigen detection in a febrile illness is lower in secondary infection. There is a 60 to 80%, reflecting amnestic serological response due to previous dengue virus or related flavivirus infection. So in secondary dengue, the sensitivity of NS antigen is 60 to 80%. In primary, it is 90%. Serological diagnosis of dengue relies on a detection of high level of serum IgM that bind dengue virus antigen in an ELISA and lateral flow rapid test. IgM can be detected as early as 4 days after the onset of fever. IgM seroconversion between PET sample is considered a confirmatory finding, whereas detection of IgM in a single specimen obtained from the patient with a clinical syndrome and that is consistent with dengue is widely used to establish presumptive diagnosis. Newer tools to diagnose dengue fever. During the course of dengue fever, there is a window period during which both NS1 antigen and IgM antibody may be negative, and biochemical and hematological clue pointing towards other differential diagnoses are absent too. This time frame was a state of diagnostic dilemma where clinicians are at a crossroad as the outcome on dengue fever rely on early diagnosis and optimal fluid resuscitation. Hence, there is a need to research other biomarker that can help differentiate dengue as a cause of febrile illness and even attempt to predict severity during this critical phase and narrow window period. In meta-analysis by Su et al., which evaluated several studies on the biomarkers such as interleukin 7, interleukin 8, interleukin 10, and TGF-B and VEGFR2 that could use as a potential early laboratory biomarkers in the differentiation between dengue fever, severe dengue, and to monitor the effectiveness of fluid therapy. A study carried out by Vatheny et al. In children with confirmed dengue fever evaluated the importance of serum ferritin and concluded that the use of ferritin as a tool to predict progression of severe dengue and the ferritin it is more than 1200 nanogram per ml as early as on a fourth day of illness and continuing into the convalescent stage. Similar data by Van den Weg et al. Provided evidence that ferritin can be used as a biomarker to discriminate between dengue and other febrile illness, and finding of high level of ferritin in patient with dengue is indicative of highly active disease resulting in immune activation and coagulation disturbance. So they are the newer tools for diagnosis of severe dengue. Dengue IgM antibody become positive 5 to 6 days after the onset of fever. Dengue IgM remain positive for 30 to 90 days after the onset of illness. During the secondary infection, IgM level are lower. Dengue IgG antibody produced approximately 2 weeks after primary infection and they are positive for lifetime. In secondary infection, dengue IgG level rise rapidly to the higher level than observed in primary infection. So, what is the management of dengue fever? It is a remarkable that disease of such complexity and potentially high mortality can be managed quite well and mortality decrease to less than 1% by appropriate fluid management alone, especially in the early phase of the disease. And this highlights the crucial role of primary care physician and other healthcare personnel at field and frontline area in recognizing the disease early and tailoring fluid therapy appropriately. The management of the child with dengue depend on the phase of illness, presence and absence of warning signs, and if he or she fit into the criteria for severe dengue. Children with no warning sign of dengue who have a normal sensorium are able to eat and drink fluid can be managed at in OPD or at home. The caregiver must be instructed not only on the type of fluid to be given, but also the importance of noting the frequency and quantity of urine output. It should be ensured that patient void urine at least once in every 6 hours, even at night. An amount must be measured by using measuring glass. It may be useful to teach patient to maintain chart containing the nature and volume of the fluid consumed along with the urine output. To avoid drink with a very high sugar content, more than 5% sugar, that is commercial drink, should be avoided in dengue management. And fruit as they can induce osmotic diuresis and spuriously normal or a high urine output. So avoid high sugar content commercial drinks and fruits with high glycemic index. Indication of hospitalization are and PICU in case of dengue fever for care. For hospitalization, when there is a presence of warning signs, inability to take orally. Oh, वहाँ पे बैठा है प्रोसेस वाला ओके उसका बर्थडे है ओके happy birthday. For hospitalization, presence of warning signs, inability to take orally, inability to quantify urine out properly, infant even if there are no warning signs, another comorbid condition like diabetes, renal disease, and morbid obesity. Social circumstances like poor access to the healthcare facility, poor understanding and awareness of disease, and inability to monitor child well at home, these are the indication of hospitalization and PSU care for dengue fever. For emergency treatment and PICU admission indication, when there is a severe plasma leakage, when there is a major bleeding or severe organ impairment, these are the indication for emergency treatment and PICU admission for dengue. Parameter indicative fluid resuscitation for management of dengue. When there is a prolonged capillary refill time, narrow pulse pressure, decreased urine output, rise in hematocrit of more than 20%, and hypotension is a late sign in case of dengue. So these are the indication for fluid resuscitation. Management principle in hospitalized patient with dengue. It includes replacement of plasma loss and timely identification and treatment of hemorrhage and the prevention and treatment of fluid overload. Replacement of fluid loss in hospitalized children with dengue obtain baseline hematocrit, blood grouping and matching along with other diagnostic investigation during the first point of contact, and this can be followed with the severe serial measurement at a given interval depending on the clinical status to guide fluid therapy and to detect occult bleeding early. And the rising hematocrit alone without any other signs of hypoperfusion is not an indication for beginning or increasing fluid therapy. However, these children need repeated clinical assessment looking for worsening dengue. Choice of fluid in case of dengue management. The choice of resuscitation fluid has been controversial, but evidence is in a favor of using non-dextrose containing isotonic crystalloids, there is zero point 0.9 normal saline or a ringer lactate solution during the initial phase of resuscitation in the patient with warning signs and compensated shock. Platelet and fresh frozen plasma must also not to be used for resuscitation. Ringer lactate solution may not be ideal in a dengue patient with liver failure as lactate metabolism is impaired in this patient. Crystalloids are safe, inexpensive, and reaction free, but their main drawback, while colloids are attractive as their osmotic potential can result in a lower volume of infused fluid and some allergic risk, and they are reported adverse effect on coagulation and the renal function. Colloid might be preferable in a severe dengue with hypotension and those with a pulse pressure less than 10 millimeter of mercury, repeated shock, high rate of fluid requirement where more, it is between more than 20 to more than 30 ml per kg of crystalloid, and if the hematocrit remain persistently high and elevated with the feature of shock despite resuscitation with crystalloids. Fluid management in dengue is a dynamic, challenging process which involves meticulous repeated clinical assessment and precise decision making to optimize hemodynamics and prevent and recognizing bleeding and mitigate fluid overload. The key to excellent outcome is timely recognition of need for IV fluid and prescribing them appropriately. The clinician should be careful not to be deceived by alertness of child in early stage of hypovolemia. Concluding remarks of this dengue, the fluid management in dengue is a dynamic, challenging process which involve meticulous repeated clinical assessment and precise decision making to optimize hemodynamic, prevent and recognizing bleeding, and mitigate fluid overload. The key to excellent outcome is timely recognition need for IV fluid and prescribing them appropriately. The clinician should be careful not to be deceived by alertness of child in early stage of hypovolemia due to dengue. So today's key message for this dengue fever. Dengue is an febrile illness caused by four types of dengue virus. There's a Den 1, Den 2, Den 3, and Den 4. Host immunity and prior dengue infection influence adverse outcome. Spectrum of clinical presentation of dengue varies from asymptomatic infection to refractory shock, bleeding, and multi-organ failure. The cornerstone management in hospitalized dengue patient is carefully titrated isotonic non-dextrose containing crystalloid fluid administration based on a perfusion status, blood pressure, serial hematocrit measurement, and most importantly, urine output. Timely recognition and treatment of shock is the most important factor in case of dengue hemorrhagic shock syndrome. Suspect occurred bleed in child with a normal hematocrit, and in a bleeding child, transfusion of fresh whole blood or fresh packed cell red cell may be needed early to optimize oxygen delivery. The role of platelet and plasma infusion are very limited in a child with dengue unless he or she is bleeding. The correction of acidosis, hypothermia, electrolyte abnormality are as important as control of source of bleeding in a bleeding child. Fluid overload is most and often a preventable complication by rational fluid and a blood product infusion and may be treated with diuretics, non-invasive or invasive positive pressure ventilation, drainage of third space collection, and colloids may have added benefits due to the high oncotic pressure. Thank you.
Thank you so much, sir. Thank you for such wonderful insights that you have shared today upon the awareness of dengue. I mean, the season is already here, and we all are experiencing dengue one at one house in our locality on a 10 house. So, thank you for sharing your insights with it.
Okay.
We'll move to the question answer session. We'll ask the viewers if they have any question, they can definitely put it across to us so that we can put it across to you. We have received a question from one of our viewers who wants to know what nutrition value one should take care of while they are suffering from dengue.
When we are suffering from dengue, what nutrition?
Yes, sir.
So, in the management of dengue, mostly there is a by the fluid management. So, during the dengue, uh, do not give these commercial drinks. There is a high sugar content. I only told, and due to osmotic diuresis, there is a it deteriorate the condition in dengue. So, do not use these sugar content in these commercial drinks, and also the fruit should not be given during the management of dengue.
Thank you so much, sir, for answering this question. We have received another feedback from one of our viewers, letting us know that they have loved the presentation that you have shared and the insights that you have shared upon the topic. So, thank you so much for sharing your valuable feedback with us. And sir is here, who has sir has listened to your feedback as well. So, would you like to say something on that feedback, sir?
Uh, yes. Any other question for?
No, sir. We don't have any other questions from the viewers. We were having the feedbacks from our viewers. So just check once more whether we have received any questions or not. We haven't
Okay.
received any questions yet, sir. So, with all your due permission and with all your last comment, we can conclude the session here for today, sir.
Okay. Thank you.
Thank you so much, sir. Thank you for your valuable time and for such an interesting topic that you have shared today with us upon the awareness that you have spread. Thank you so much, sir.
Okay. Good day. Good night.
Good day, sir.